Dr. Ranganathan, sir, can you hear me? Sir, Dr. Ranganathan, sir, can you hear me? Good morning. Sir.
I'm back on. There was some problem. Okay. Yeah, I'm in. I'm very much in. Yeah.
Sir, Dr. Ranganathan, sir, can you hear me now?
I can hear you, Riaz. Good morning. Can you hear me?
Yes, sir. Is
Am I
it clear, sir?
Absolutely.
My voice is clear now, sir. And
Yeah,
your voice
absolutely.
is fine, sir. Thank you.
Fantastic.
So we'll start in 5 minutes of program.
Sure. Thank you.
Okay, sir.
Dr. Ranganathan, good morning. Dr. Sripatrao here.
Good morning, sir. It's a pleasure to meet you.
How are
sir.
you?
I'm fine, sir. How are you doing?
Oh, very nice talking to you after a long time.
I know, sir. I mean, I was very excited when Vishnu said you
No,
join.
actually I was busy with some academic accreditation program, but I told them I'll just come in the beginning and say hi to you and then go back.
Oh,
I would have loved to be with your program, but then meeting is going on in the university.
Oh, thank you very much, sir. I appreciate it. It's really nice.
No. I'm going to miss your talk anyway, but nice seeing you. And how are you then? Doing well?
Doing well, sir. Thank you, sir. Yes, sir. Hope you're
Come
doing
sometime
well.
to our campus here. Some occasion after this COVID. You should come.
Definitely, sir. Definitely.
Yeah.
Look forward to meeting you.
All right. Nice talking to you, Raghunath.
Yeah. Thank you, sir. Thank you very much.
All the best for the program, yes.
Thank you, sir. Thank you very much, sir.
Sir, Dr. Akhtar, sir?
Yes, I'm fine. I'm here.
All right, sir. So we'll start the program in another 2 minutes. Thank you.
Yeah.
A very good morning, everyone. On behalf of the Department of Oral Pathology and Microbiology, a very good morning, everyone. On behalf of the Department of Oral Pathology and Microbiology, Yenepoya Dental College, and Indian Dental Association Dakshin Kannada branch, it gives me great joy to welcome you all. Ours is a department that goes back 28 years with resources and expertise put together painstakingly by generations of oral pathologists. The department, with the help of our ever supportive Dean, Dr. Akhtar Hussain, is always enthusiastic about furthering research and doing our bit for the future and hope of oral pathology. So, today, it is with immense pride that we will be conducting today's webinar on the topic Diagnostic Adjuncts and Techniques in Oral Lesion, which is through Google Meet and also streaming live in YouTube. Before we commence, I would like to welcome our Dean, Dr. Akhtar Hussain, and I request him to kindly deliver the welcome address.
Good morning. Dear Dr. Ranganathan, the President of Asian Society of Oral Maxillofacial Pathology, Dr. Riaz, Head of the Department in Pathology in Oral Pathology of Yenepoya Dental College, Dr. Jitesh, the President of IDA, Dakshin Kannada, my professional colleagues, faculty members, graduate students, and interns, a very good morning to you all. I'm extremely happy that today that the Department of Oral Pathology is doing a very useful webinar in a topic on diagnostic adjuncts and techniques in oral lesions. It's important that every clinician is abreast with the knowledge to identify any kind of oral lesion in our practices. It's natural, but sometimes we tend to forget what is taught in the colleges. And then also that we see these lesions once very rarely. So now that you also see it once in a way, so you may not be remembering certain things. So such webinars are definitely mandatory to refresh our knowledge so that the diagnosis can be achieved with confidence early, because early diagnosis can eliminate unnecessary pain and expenses to the patients. I'm very happy. You see the crowd, 250 people online. Plus, I think the rest are all on YouTube. It's a tremendous response. It's because I'm sure people want to listen to Dr. Ranganathan, an eminent speaker and a great orator. And we are fortunate to have you here, sir. I'm sure this webinar will go a long way in refreshing our memories in our practices. I'm on leave today, so I'm calling from my home, and I still be attending this webinar. And I wish all success, and I congratulate Dr. Riaz and his team for conducting such a wonderful webinar with so many attendees. Have a great day. Thank you.
Thank you, sir. I hereby request Dr. Riaz Abdullah, Head of the Department of Oral Pathology, to address the gathering.
Good morning, everyone. Respected faculties of Yenepoya, outside faculty, postgraduates, interns, and others. Welcome you all of you all for diagnostic adjuncts and techniques oral. Is that we have taken this topic aptly to mainly bridge the gap between clinician and an oral pathologist, and to conclude with apt diagnosis for the benefit of the patient. So rightly we have chosen this topic so that we have a platform of the Indian Dental Association. Dr. Jitesh is here, the president. So we took this topic so that we can bridge the private practitioners and the oral pathologists and other clinicians to come out with very apt platform for diagnostic criteria. So rightfully, Dr. Ranganathan is an expert in this field, and he will be speaking on this topic, diagnostic adjuncts and techniques in oral lesions. About our department, like the MC Priyanka has told, the Department of Oral Pathology is established in the year 1992 with a robust alumni of more than 2,500 undergraduates. I think more than 2,500 undergraduates. Is it clear? 2,500 undergraduates, 600 postgraduates, and research scholars, having many accolades and achievements to its credit. It strives, the department strives to provide a state-of-art oral diagnostics and molecular pathology while excelling in research activities and instilling a holistic approach in dental education among students. The department contributes its expertise in fostering interdisciplinary collaboration and providing exemplary education and scientific accommodation. With these few words about our department, we thank Dr. Ranganathan again to accept for the webinar series which we are planning for the whole year. And this is the first webinar series for this year from the department. So, I would like to once again thank the big response from the audience. We have the full the Google Meet category. We have a good response from the YouTube live stream also. So thank you one and all for being a part of this, and stay safe and wish you happy presentation and enjoy it. Thank you.
Thank you, sir. I now request Dr. Jitesh, President, Indian Dental Association, Dakshin Kannada branch, to address the gathering.
Good morning, dear participants. In this age of globalization, knowledge has to be shared beyond boundaries. IDA DK branch being an esteemed body of clinicians and the oral pathology department being an extremely academic, these two bodies are organizing a webinar in a very useful topic, especially for private practitioners on diagnostic agents and techniques in oral lesions by an eminent speaker like Dr. Ranganathan. I wish the webinar and the organizers all the best for successful conduct of this webinar. I thank Department of Oral Pathology, Yenepoya Dental College and Yenepoya University for having this purposeful webinar with the IDA DK branch. Thank you and all the best.
Thank you, sir. I hereby request Dr. Vishnudas Prabhu, Professor, Department of Oral Pathology, to introduce the resource person.
Good morning, ladies and gentlemen. Good morning, ladies and gentlemen. The name Dr. Ranganathan needs no introduction. A proud alumnus of Government Dental College, Chennai, Dr. Ranganathan completed BDS with accolades by standing first in the university with gold medals. He went on to complete MDS from his alma mater in the year 1990. He then traveled to Ohio State University and completed his MS in the year 1996. He was awarded the fellowship of the American Academy of Oral and Maxillofacial Pathology in the same year. He obtained PhD in the year 2010 and was also awarded the fellowship of the Indian Association of Oral and Maxillofacial Pathologists in the year 2010. Sir has been in the editorial board and has been a referee in many national and international journals. He has held many distinguished academic positions in reputed national and international institutions. He has also held many prestigious positions. To name a few, he has been the Secretary of the Indian Academy of Oral and Maxillofacial Pathologists for 2 consecutive terms. He has held the coveted position of the President of the Indian Association of Oral and Maxillofacial Pathologists in the year 2015 to 2016. He has been the Asian Counselor for International Association of Oral Pathologists. He has also been the Secretary General of Asian Society of Oral and Maxillofacial Pathology. He was the first Indian to hold this post. And ladies and gentlemen, we are proud to say that he has been elected as the Secretary of International Association of Oral and Maxillofacial Pathologists. He is the first Indian to hold this position. He is currently also holding the position of President of Asian Society of Oral and Maxillofacial Pathology. Sir is a prolific researcher. He has more than 150 publications, and contributed to more than 100 national and international presentations. Ladies and gentlemen, please put your hands together for Dr. Ranganathan, Professor and HOD, Department of Oral Pathology, Ragas Dental College, Chennai, and Research Director, Chennai Dental Research Foundation, and welcome sir with a big round of applause. Thank you.
Thank you, sir. I now request the resource person, Dr. Ranganathan sir, to begin the webinar. And I also request the audience to raise the questions in the comment box. The queries will be answered at the end of the session. Over to you, sir.
Very good morning to you all. Am I audible? Is the voice clear?
Yes, sir.
Yeah, good. If at any point in time my voice falls down, somebody can send a message via the chat box to me. I'd appreciate that. Thank you. Thank you, Dr. Vishnu, for the very, very kind introduction. Respected Principal Dr. Hussain, Yenepoya Dental College, Professor Sripati Rao, the Pro Vice Chancellor, Dr. Professor Riaz Abdullah, Head of the Department Oral Pathology, Yenepoya, Professor Vishnu Prasad, the very, very active and popular Vice President of the Indian Association of Oral and Maxillofacial Pathology and a close friend of mine, Dr. Jitesh, President, IDA, Dakshin Kannada branch. It's a pleasure that you have given me an opportunity to share some time with you all this morning. A few weeks back, I spoke to Professor Riaz Abdullah, and he was saying we should do a seminar involving the IDA. And I immediately told them it's always a pleasure to talk to the IDA members. Always a pleasure to talk to my association members, of course, but IDA members and practitioners, because at the end of the day, the practitioners are the ones who are treating patients, and the benefit of whatever we learn and teach should percolate in patients' management. With this few words of introduction and welcoming all the registrants and my colleagues to this seminar, the first one conducted by the Department of Oral Pathology at Yenepoya, I'd like to start. Can I present now? I can get my PowerPoint going. Is my screen visible?
YouTube
Yes, sir.
It's visible, right? Can you hear me? Is it visible?
Yes, sir. Yes, sir.
Because the PowerPoint covers the entire screen. In case I drop out, send a message that will be reach. All right. My topic is going to be on diagnostic adjuncts, and let me start without any further ado. Okay, so those of us who practice or involved in handling patients, there are three questions we face every day in our practice. The first question is of the hard tissue or the soft tissue, what is it? And when it comes to soft tissue, the biggest question that the patient puts forward very apprehensively is cancer. And sometimes what happens is they would not even use the word, excuse me for a minute here, yeah. They won't even use the big C word. A lot of patients are hesitant to use the C word, and they will say, should I be concerned? It's something very scary. Is it something which can be treated? So this big C word is a problem as for day-to-day practice. And once you decide whether it's cancer or you think it's suspicious of cancer, the next question which follows is, do I really need to take a biopsy? The B word is another scary word as far as patients are concerned. The moment you say biopsy, almost everybody presumes that it's going to be cancer. It's not necessarily so. So these are the three important questions which are in front of when the patient is sitting in your chair. What exactly are you looking at? Is it cancer, or is it something the patient should be concerned? Is a biopsy needed at all? I hope to address all three of these questions in today's presentation. Now, this is something which is taught right from when we enter the third year of our undergraduate degree. Before we diagnose anything, we need to take a very, very proper history. It's very important you do that, and this cannot be overemphasized. And of course, you note down all the clinical features in a pre-formatted questionnaire, which varies from institution to institution. And based on the history and the clinical features, you come to a provisional diagnosis. And then you order for some investigations, and then you club the triad of history, clinical, and investigation, and then you come to a diagnosis. All these three arms are very important in the clinical context: history, the clinical component, and the investigation which you're going to order for the patient or for that particular condition. And this will help you to clinch the diagnosis. Let me give you some examples to highlight the importance of these factors. How important is history? A lot of times I see when you start your practice, the moment the patient complains, there is a temptation to immediately pull out a prescription pad and write out something or advise the patient something. But it is important to take a thorough history, and I'll show you a very interesting case we saw a few years back in our practice. This patient was treated for abscess ulcer multiple number of times. It kept coming back. I mean, you can see that you're looking at the sock palate, a nice huge aphtay, probably we call it a major aphtay. On further examination, the patient had huge aphtase in other parts of the oral mucosa, and it was diagnosed rightly so as major aphtay, and the patient was treated accordingly. Everybody would agree that that would be the correct way to go clinically. But what was interesting was, we took the history and did a thorough clinical examination. The patient also complained of some lesions which were very itchy and nodular in the lower limb, and itchy areas on the nape of the neck, where the patient would scratch, leading to excoriations. And this kept happening repeatedly along with the abscess ulcer. So there was a dermatologist who was treating this, a dental surgeon who was treating the aphtay, and both of them didn't know what the other one was doing, and the patient didn't think it was important to mention either of these to the other consultant. So we put this all together, and I think a lot of you will realize that it's not just a simple aphtay, and I think you have come to the correct diagnosis. This is a case of Behçet syndrome, which has multiple clinical manifestations, which include changes in the eye, that is ocular inflammation, and patients may have orogenital ulcerations, and usually associated with a systemic immune problem called the HLA-B51 complex. This is usually in Asians and Southeast Asians who live along the Silk Route, if you remember your history. And the interesting thing is these patients tend to have major aphtay, and these aphtay are very large and distributed more closely towards the oropharynx rather than throughout the oral cavity in just for the aphtay ulcers patients have. So these patients can present with either problems with the eye, problems in the orogenital region, or skin lesions, such as erythema nodosum, folliculitis, or acneiform lesions in the face. So these patients can land up with any one of the consultants. They could land up with an eye doctor, or general physician, or a dermatologist. So, and unless you take a comprehensive history and realize that the patient has got multiple lesions in multiple areas of the body, it would be very difficult to clinch the diagnosis of Behçet, which should be treated a little bit more aggressively, and there's a lot of counseling involved in treating this condition as opposed to your regular major aphtay. And that's a very, very simple test you could do. This is called the positive pathology test. All that you need to do is take a needle, probably a 20-gauge needle, and just introduce it into the dermis of the patient. You don't have to inject any drug, nothing. Just introduce it into the dermis of the forearm. Forearm is a good place to do it, like for all allergic reactions. And immediately the patient will develop a solid elevation or a reaction where you have injected the needle, whereas a normal patient is not. It's a very easy clinical diagnostic feature. And you could probably do the pathology test only if you realize that the patient, in addition to the aspect, has got multiple problems in other parts of the body. So this is a very important take-home message. Before you even look at the lesion in the oral cavity for which the patient is complaining, take a thorough history. Very many a times, you can narrow down a diagnosis even before you examine the patient. That's the point here. Coming clinical detail, and I don't have to emphasize this to you. Most of you are clinicians or handling patients at some point in time, and if you're a student, you're going to handle patients eventually. Clinical details are, of course, very important, as important as history. I'll show you two cases, and these cases are really old cases from my files. So some of the pictures may not be really ideal, but I'm sure they'll convey the message which I'm trying to point here. I remember this case very clearly, and there was a colleague of mine who hands the radiograph, and tells me that this patient has got highly mobile teeth, and he had also not seen the patient, and somebody had given him the radiograph and suggested that the teeth are highly mobile, has periodontitis apparently. Do you think we can save the teeth? We need to looking at a picture of lower anterior mandibular region. And the temptation is to say, yeah, the teeth are very bad. Please go ahead and extract and, do proper processes, whatever the patient needs. That's a very dangerous thing to do, especially giving a diagnosis using radiograph. And I still do get, people passing on radiographs and asking, what do you think the diagnosis could be? So we were just discussing and said, let's take a look at the patient and see what we can do. And that's what the patient had. You just need to take one of the patients and realize that the patient is obviously a malignancy. In this case, it was squamous cell carcinoma. And that's the radiographic picture. So it is very dangerous to diagnose just based on a radiograph for a clinician or just based upon a microscopic slide for a pathologist. And then I can show you numerous cases where the biopsy was not from a representative side and it's misdiagnosed if you don't look at the patient. And there is always this question, fortunately it doesn't happen in oral pathology, but happens a lot in general pathology where the pathologists do not see the patient. And the question is, why do pathologists need to know the clinical features? A lot of times, avoid a lot of problem and re-biopsies if we have all the clinical features in place. So that's my second take-home message. Do not examine the patient before taking a thorough history, a thorough general clinical examination, and then, of course, the oral examination. This is a very old slide from my files. This is once again to show how radiographs can be very deceptive. These are really old radiographs, not the digital ones. And this is a patient, both of them are occlusive view of maxilla. And so this is a nice cystic lesion between the central incisors, diverging the two roots, pushing the two roots away. This is a classic nasopalatine cyst, a textbook picture. The patient on the right also had a similar lesion and had multiple root canal treatment. I mean, you can see this. A lot of root canals have been attempted, re-root canals have been attempted, but the patient didn't heal at all. Then, after many months of repeated treatment failure, and the patient didn't want the teeth to be extracted, the dental surgeon thought that let's just open it up and take a specimen of it. This is a true nasopalatine cyst, and this turned out to be an intraosseous carcinoma. Very, very rare. Not the first which jumps to your mind as far as provisional diagnosis is concerned. But the point here is, if you're managing your patient and the patient is not responding to your routine treatment and you feel there is something off, do not keep on changing your treatment unless you do an investigation to find out what the correct diagnosis is. So in this case, the investigation was because multiple treatments like root canal and periapical surgery, the patient kept having the problem. So finally, the patient went in for a biopsy and it proved to be a squamous cell carcinoma. There are numerous instances where periapical lesions have turned to be lymphomas, squamous cell carcinomas, and they can mimic periapical cyst or granuloma. So investigations are also important. So this is the triad of history, the clinical features, and investigations where you feel it is absolutely necessary to narrow down your provisional diagnosis is very, very critical if you need to manage your patients appropriately. That's another thing to remember. Clinical details are very important, but that's only a part of the problem. You need to take a 360-degree view of what is commonly called as a holistic view of your patient, just not one feature. Now, this is a case that we saw recently, and I projected to a lot of my colleagues in the IDA. This was a patient with oral submucous fibrosis. You can see numerous stains here. The patient had difficulty in opening the mouth. There was this red patch in the mucosa. And we took a biopsy. The patient was lost to follow up. And within a week or two after the biopsy, the patient complained that she had a huge growth. And then by the time the patient presented to us, it was almost a few weeks. And this was the lesion. Now let's look at the history and the clinical features. This is oral submucous fibrosis, a potentially malignant condition. You've taken a biopsy, and within a few weeks, there is a rapid proliferative growth at the site of the biopsy. and the tendency to immediately jump into a conclusion that it has all the features, potentially malignant problem, rapid growth, there is always a high risk of cancer, and the patient has got habits, that this could be a squamous cell carcinoma, and do treatment accordingly. But surprisingly, the histopathology was that of a fibroepithelial polyp, which is a benign reactive lesion. And we took multiple sections and examined the lesion completely. And the lesion was excised thoroughly, and the patient is doing well. So sometimes what you're taught in a clinical, what you're taught in your academics, you need to apply that in clinical practice. And as you see new cases, you add on to your existing knowledge that you've been taught. So it's not that all things which look like a nasopalatine cyst may turn out to be a squamous cell carcinoma. I should tell the patient that it could be a cancer. And on the other hand, things which can look malignant, like a rapidly proliferating lesion, need not necessarily be malignant. This is where investigation is very, very important. And the investigation, as far as most of the soft tissue lesions are concerned, is, of course, biopsy. Okay.
Hello,
That was yeah.
Yes, sir, Dr. Riaz here. Sorry to interrupt you.
Yes, please.
Hello, sir.
Yes, tell me. I can hear you.
Yes, sir. Some places in between your voice is a little low. Some people are telling, sir.
Can you hear me now? Is it okay?
Distance from the laptop, probably, sir. Just wanted to inform you.
Yeah, I'm on
Just wanted to let you know,
Bluetooth.
sir.
I'm on Bluetooth. Is this a problem? I mean, the person who's comparing it, the control center, can you hear me very well?
Some voice interruption is coming sometimes.
Is everybody's mic muted? Are you sure?
And everybody's mic is muted, sir, from our side.
Now am I audible?
Yeah, now yes. Now it's much better, sir.
Okay, fine.
Maybe the distance problem.
Yeah, no, okay. Let me make myself
At some point, there is an interruption. That's the only thing. Otherwise, it's fine.
Okay. Just give me a missed
Yeah. Continue, sir. No problem.
Just give me a missed call. I have my phone in front of me. Just give me a missed call. That's a problem.
Yeah.
Okay, you want me to go back to the previous slide?
No, sir. It's fine, sir. You can just continue with the same. Only thing is, at times it was slightly breaking and it was not clear, little low. Maybe you may have to come a little closer, or your probably your mic has to be kept closer to you, sir. That's the only reason.
Okay. Let me just cut off my other Bluetooth. I'm on a Bluetooth microphone, so it should not be a problem. Let me make sure my other things are cut off.
Maybe
now
Bluetooth is a problem, sir. Probably.
No, it's okay now.
Yeah, now it's better, sir. Now it's clearer. Fine.
All
Please
right.
continue, sir.
Let me go. No problem at all. Let me go very, very slowly,
Yes.
so that somebody can raise an issue if there is a problem.
Thank you,
The
sir.
question is it cancer? Will it become cancer? We use a lot of terms to something which is not cancer already. And the earlier term used to be pre-cancer or pre-malignant lesion. Now, of course, everybody uses the term potentially malignant. So when we say potentially malignant as pathologists, we mean pre-cancer. The four most common things which are likely to face in the clinical context, which are pre-cancer or what we now call potentially malignant, are leukoplakia, white patch, erythroplakia, lichen planus, and oral submucous fibrosis. And for the interns and those who are starting your practice, that's how erythroplakia looks like. Very red, inflamed area. And if you're not experienced, you will mistake it for an inflammatory lesion. Fibrosis, which I'm sure is and prevalent in this part of our world. It's because of areca nut chewing. There is pallor, a lot of fibrosis, and the patient finds it very difficult to open his mouth. Lichen planus is very classic. Reticular areas could be white and red mixed, but you see very, very fine striae. Occurs in the buccal mucosa, different types. You can have reticular, you can have erythematous or erosive types, like what you see more posteriorly. And then leukoplakia are just white patches, can occur anywhere in the oral mucosa. Here you're looking at leukoplakia of the gingiva. And then we have a more recently described entity, which many of the interns, I do not know if they're aware of this. It's called proliferative verrucous leukoplakia. It is essentially leukoplakia which has a verrucous surface and is there throughout the oral cavity. It may be there in the gingiva, in the buccal mucosa, in the floor of the mouth, the palate, the ventral surface of the tongue. So multiple areas of leukoplakia with a verrucous surface. And these lesions are very recalcitrant. Even if you excise them, they keep coming back. And a lot of times, they may not be associated with habit. So these are really very difficult to manage clinically. I'm sorry about that. And then you have more newer sort of described entities. The moment you look at this, the patient is obviously has habits. You can see a lot of stains. You can see severe discoloration and pigmentation in the posterior part of the oral cavity. And this huge growth on the lateral surface of the tongue. I mean, it looks like a cancer. It is probably a cancer. But what happens is there is a subgroup of lesions when you biopsy this. And when we look at it under the slide, there is proliferation, but there is no evidence of infiltration into the underlying connective tissue. So by definition, these are not malignant lesions. They look like malignant lesions. They grow in a very verrucous pattern, but they are not squamous cell carcinoma. And these are called verrucous hyperplasia. And a lot of us are trying to pool our resources and cases as far as this lesion is concerned. And we're really trying to find out what exactly is going on here. Because it behaves like a squamous cell carcinoma. And a lot of these patients have habits, so the history is appropriate. But histologically, it is not cancer. So how do you manage these patients? Are these going to become cancer? So there's a lot of work going on as far as verrucous hyperplasia. And then you have lesions like this. This is a patient with oral submucous fibrosis and has this red lesion here. And like you saw a few slides back, it is red, looks inflamed, patient with habits and submucous fibrosis. The tendency is to call it erythroplakia. But when the biopsy was done, this turned out to be a squamous cell carcinoma or an oral cancer. So I'm sure that this entire range of lesions which I presented the past few minutes has made you realize that things which look malignant need not necessarily be malignant. And things which look malignant can be innocuous and vice versa. Also, you need to use all your resources, namely the proper history taking, proper clinical examination, and investigation to come to a final diagnosis. You have to render a perfect final diagnosis and manage the patient appropriately. Okay, so what is the goal of a good clinician? I said earlier what was called as precancer is now called oral potentially malignant disorder. The reason is for the interns, all these lesions do not become cancer. When you say pre-cancer, you mean that it's one step before cancer. And all these can become cancer, but that is not necessarily true. And that's what makes handling the earlier term pre-cancer very difficult. So we call it potentially malignant because all the white patches or red patches like leukoplakia and erythroplakia do not necessarily become cancer. Only a small subset becomes cancer. And this talk is going to focus on how do you find out which subset becomes cancer and which doesn't. So in an ideal clinical scenario, you need to catch and treat the patient at this stage, erythroleukoplakia or submucous fibrosis, before it becomes cancer. So once it becomes an oral cancer, diagnosis is very straightforward, management is very difficult. So the clinical goal here is to catch them at a very, very early stage. And to do that, you need to know how these lesions look like, and you need to have them in your differential diagnosis. And I'm asked this a lot of times where I go, can dentists actually make a difference by looking into the mouth? Because there are screening procedures like pap smear for women, uterine cervix, mammograms for diagnosing breast cancer. So is screening for oral cancer really feasible? Can dentists make a difference? Yes. Why? Most of the potentially malignant diseases, I shall be calling them OPMD, which is oral potentially malignant disease, precede oral cancer, especially those which are associated with habit. So like my previous slide, you should catch them at that stage and not when they become cancer, and dental surgeons can contribute to this. This is very important, like the erythroplakia I showed you. What looks like a potentially malignant disease may already be cancer. So you need to biopsy all these lesions. So there's no two ways about that. And the last statement is the most important. Asymptomatic cancer, which even the patient is not aware of, patient does not have any complaint in a very, very early stage, are more likely to be detected in a dental setting. And I think the president of the IDA made a point of saying that a lot of us, when you go into practice, we forget what has been taught, and there is this risk of missing these lesions. In fact, in certain countries, if you are treating the patient for a crown or an implant or a restorative procedure or an orthodontic or a periodontic procedure, if you miss diagnosing a leukoplakia, they can take a legal action against you. So complete oral examination of the soft tissue is very important. It may not be a legal binding here in our country, but it is a moral binding that you catch this at a very, very early stage. That's very important. And there are a few important statistics which as dental surgeons we should know. In oropharyngeal cancer, a professional delay of longer than 1 month means the cancer is going to be diagnosed at a late stage. What does this mean exactly? So cancer, you have 4 stages, stage 1, stage 2, stage 3, and stage 4, 1 being the least severe and stage 4 being the most severe. If you diagnose it at stage 1, the cure rate is almost 100% with current technology. Whereas if you diagnose it at stage 3 or 4, the chances of patient surviving falls to less than 20%. And the difference between stage 1 and stage 3 can be as small as 1 month. If you delay the diagnosis by as much as 1 month, it's a matter of literally life or death for the patient, good cure versus bad prognosis for the patient. So as dental surgeons, we need to be very, very alert and diagnose these conditions at a very, very early stage to help the patient. And of course, when you delay the diagnosis, there is increased morbidity and mortality. So as dental surgeons, we can definitely make a difference to the life of the patient if you catch these lesions very, very early. Which comes to the main purpose of our topic, how do you diagnose? Ideally, you need to diagnose them at a very, very early stage. This looks like cancer, it's not cancer. It does not look like cancer, but it is cancer. So how exactly do you proceed when you see these lesions? So what are the screening tools for oral cancer? The most important is, of course, patient education. And I think IDA is doing that a lot, approaching the public and asking them to how to examine. Just like, hello. Yeah, hello. Okay, I think there's a disturbance there. Just like how patients are taught to do a self-breast examination to avoid routine mammograms. And then, of course, visual examination by the dental surgeon. These are 2 valuable techniques, and they are very, very important in our armamentarium against, fighting against oral cancer as a whole. And then, of course, a lot of people use what is called exfoliative cytology and brush biopsy. I should talk a little bit about them and are they really useful or they're not useful in the oral context. And then there are adjuncts, and this is what I intend to talk about: toluidine blue, chemiluminescence, and fluorescence imaging, and how to use it in the clinical context to make a diagnosis. And now we have rapid technological advance in analysis of saliva and so-called liquid biopsies. I'm not going to really emphasize on that, but I will point to some references. You can go back and look at it because that may be beyond the scope of this presentation. Interestingly, just a thorough, good oral examination has got the sensitivity and the specificity of as high as 94 and 98%, as good as any test except for biopsy. So if you can actually train yourself to look carefully into the oral cavity, or if you can tell your patients to do an appropriate self-examination so that when they have a doubt, they can report to you, that's a beautiful technique to catch these lesions very, very early. Of course, there are different methods to help you. You have cytology, you have brush biopsies, you have aspirations, you have punch biopsies, and you have excisional biopsies. So let me talk a little bit about each of these. This, I'm sorry, the reference is not here, but this was taken from JADA many years back. This actually shows what is the difference between a brush biopsy, a fine needle aspiration biopsy, and exfoliative cytology. In brush biopsy, you use very specialized brushes. And this surface you're looking at here with a lot of cells is the epithelium. And the pink is the connective tissue. So the brush goes in the epithelium, pulls out a lot of cells, the superficial cells, the intermediate cells, and the basal cells. And then you examine them. In fine needle aspiration, you just put a needle and then you aspirate a bunch of cells and then you examine them. Exfoliative cytology only reaches this level of the epithelium, so you get only superficial cells. So in a brush biopsy, you get cells from the basal, intermediate, and superficial. Fine needle, you get all the cells, but you really can't say which because the cells are jumbled up as an aspirate. Exfoliative cytology, you get only the superficial cells. And the point here to remember is cancer starts in the basal area, right here, where the cells are multiplying. So it's not difficult to understand that exfoliative cytology in most situations in the oral cavity is ineffective. In the uterine cervix, the mucosa has a totally different histoanatomy, so it works very well there. Whereas in the oral cavity, it tends to be heavily keratinized, and even the non-keratinized mucosa tends to be very thick. Exfoliative cytology has got a limited value because it takes only superficial cells. And changes in potentially malignant and cancer happen right here in the basal area. A little bit on oral CDX, there was a lot of discussion about this a few years back, and it totally sort of fell out of popularity because of its limitations and because of its expensiveness. There were a lot of investigators in India who tried to use, this is the commercial term, oral CDX, which was marketed by an American company. A lot of people in India used modified brushes, and I think there are a lot of projects still going on, particularly dissertations, that they try to scrape these cells using modified brushes and try to examine this to see if we can predict cancer. This is the oral CDX from CDX laboratory, and that's how the brush looks like. You put it and do a rapid clockwise turn so that you get cells and there are some bleeding spots. This is similar to the slide which I showed you earlier. This is a superficial specimen, whereas the CDX, this is their photograph from the company, takes all the cells right from the basal to the superficial. And then you use a computer because you get hundreds of cells and it's very difficult to eyeball them by any one pathologist. It takes a lot of time. So a computer does an analysis, you evaluate. The ADA felt it was okay, but the rider that does not replace scalpel biopsy screening. And then the results come out like this: negative, which means no cellular abnormalities; positive, there is definitively cellular evidence of epithelial dysplasia or carcinoma; atypical, there are abnormal changes warranting further investigation. So for both the positive and the atypical, you still need to go back and do a conventional biopsy before you start treatment. No oncosurgeon is going to treat these patients without a biopsy. So eventually you need to biopsy these lesions. But they can be good screening tools to rule out negative patients so that you can narrow down the patients for whom you need to do the biopsy. This is the reference I'm talking about. It's one of the chapters which I've contributed to. Make a note of that. There's a lot of talk about the different fixators, what you can use in the clinical context, how do you need to transport the specimen, and what are liquid biopsies and salivary diagnostics. You can refer if you're interested. So the gold standard for diagnosis, be it cytology or aspiration, is biopsy, as far as oral cancer is concerned. So whatever technique you use, you need to biopsy eventually. The biopsy could be incisional or excisional to arrive at a diagnosis. Then comes the question, okay, I have this lesion in the mouth. I think it is cancer, or I don't think it is cancer. I think it's a potentially malignant disorder. I need to biopsy. So when do I biopsy and where do I biopsy? This is once again a flow chart of how do you make a decision to biopsy. The patient presents with an abnormality of the mucosa, could be a leukoplakia, erythroplakia, or any such similar lesion. You do a thorough history, clinical, systemic, and local examination. And then if you think it's a benign condition, you wait for about 2 weeks, treat appropriately. If it heals and there is no suspicion of malignancy, you can treat it. Patient is disease-free, you follow up. If the disease is still present, go ahead and do a biopsy. But when you examine, if you know that it's been there for more than 2 or 3 weeks and you think it could be a malignancy, you straight away do a biopsy and treat appropriately. And all these patients need to be followed up. This is very important because when a patient has cancer in the head and neck, there is a 20 times higher risk for these patients for getting a second cancer within the next 3 to 5 years, a new tumor. This is a big problem in head and neck cancer. Patients who get a cancer, even if they're treated very effectively, they have a 20 times higher risk, and even if they stop the habit, to get a new cancer, a new primary within 3 to 5 years, or sometimes as late as 10 years. So even if the patient is cured of cancer, you need to follow them up periodically. And this is a concept of failed cancerization, which is a topic by itself. But what you need to remember is even if the patient is cured of oral cancer, you need to follow them for at least 10 years periodically. And you need to tell the patient that they carry a higher risk of getting a new malignancy within the oral cavity. So what are the features that may raise the suspicion of malignancy? A persistent red or white patch which has been there for many weeks, more than 2 weeks, a non-healing ulcer, sudden tooth mobility without apparent cause, any lesion in the jaw or in the mucosa if it becomes indurated on palpation, or within the jaw it causes paresthesia of the lip or tongue. If the patient says that they have a numb feeling or an odd feeling in the lip or the tongue, that's a very, very high indication of malignancy. A difficulty in swallowing, especially when you have tumors in the posterior 1/3 of the tongue and in the oropharyngeal area. Chronic earache. I have seen patients with cancer of the lateral surface of the tongue. Their only complaint was pain in the ear. And they have seen the ENT a lot of times. They've examined the throat and everything is normal. The ENT says that everything is normal. That was due to a carcinoma in the posterior 1/3 of the tongue. And these areas are very tricky to examine. So unless you do a thorough examination, you may miss them. Any trismus of unknown cause without any evidence of infection or damage to the temporomandibular joint. And of course, persistent cervical lymphadenopathy. Of course, you need to rule out tuberculosis, which is pretty rampant in India. But other than that, when there is an absence of any other signs of infection, persistent cervical lymphadenopathy, all these should raise the suspicion of malignancy. So, back to biopsy. Now, this can be tricky sometimes. It may not necessarily be very straightforward. You have 2 lesions which I have here in front of you. This is a leukoplakia, maybe a small ulcer right there. This is an erythroleukoplakia, a combination of leukoplakia and erythroplakia, and you have a bleeding spot. I do this, I put this a lot of time in front of the clinicians who I interact with and ask them, where do you think you'll take the biopsy? And many times they will correctly tell me that this is where I should take a biopsy here, where it looks red and white. And sometimes they will say that you have to take a bit of normal along with leukoplakia right here. That's also true. But this is the appropriate site to take for this particular lesion. But when you have a huge lesion like this, it is important that you take it from multiple sites. And this is very, very important. And we work with our oral surgeons very closely. And it is, if you probably take a biopsy from here, you're only going to see leukoplakia or dysplasia. If you take it from here, you may see dysplasia and early cancer. And the frank ulceration and induration here, it may be frank cancer. If as a clinician, you give us only a biopsy of this, and if you've forgotten my initial caveat that you should look at the patient clinically and the pathologist is not seeing the patient clinically, and he or she gives a report of just dysplasia, you're going to send off the patient and follow up appropriately, of course, after advising them on habit cessation. And then you're going to miss cancer. And if you miss it by 1 month, you know by now that it can go from stage 1 to stage 4 oral cancer. And basically, that's not very good. So many of the times when you have a variable lesion like this, it's a variable clinical presentation, you need to take multiple biopsies, and that can actually clinch the correct diagnosis. So how do you decide where to take? Why shouldn't I take it here? Why shouldn't I take it here? You say take it here. I prefer this. This looks more, has got more of a combination of uniform and vertical. Why? This is where diagnostic adjuncts come into play, or what we call as diagnostic aids. They're called diagnostic aids and diagnostic adjuncts because you just don't use them blindly. They are an aid to or an adjunct to your history, your clinical examination, and your provisional diagnosis. So you do not look at the lesion and say, I don't know what this is, let me use one of these diagnostic aids and find out what it is. It's not going to work. You need to have the history, the clinical examination. These will tell you where to take a biopsy and how extensively to take, and that's all they're going to do. And they also have their limitations, and that's what I'm going to discuss here today. The three most commonly described techniques are chemiluminescence, toluidine blue, and fluorescence or autofluorescence. There are multiple techniques. I'm going to talk about something called VisiLight or chemiluminescence. It's actually not available anymore in India. So they replaced it with VisiLight Pro, which uses the blue LED and depends on fluorescence, which we'll talk about as a clinical adjunctive aid. VisiLight, once again, this is just to explain to you the principle by which it works. There are numerous other techniques. There are people who use paint a mucosa with Lugol's iodine and then decide for the glycogen content. But these three techniques are the most commonly used. VisiLight is by Zilla Pharmaceuticals. It's not a diagnostic tool. It's an excellent tool for screening to decide whether you need to take a biopsy. It basically contains a stick like this and some reagents to clean the oral mucosa before you use it. This is one of our cases where the patient had ulcer on the lateral surface of the tongue, very huge. Some areas were indurated. The base was a little bit necrotic. There was erythroplakia in some areas, and we needed to know, excuse me, where to take a biopsy. So when you compress the stick, it releases a light like this for a limited period of time. You expose the oral mucosa and look at these white color changes. What are these white color indicative of? Now, this is what happens. This is the oral mucosa, and this is the epithelium and connective tissue. When you have a lesion like this, what happens? The abnormal tissue will reflect the light and it will appear white in color, whereas the normal epithelium will absorb all the light and appear dark in color. So obviously you take a biopsy from where it is white in color. Then you have a test called the Aura test, or some of you may know them as a toluidine blue test. You can prepare this in your lab. A toluidine blue is a metachromatic dye. It stains the DNA within the cell. The principle behind it is, in a cancer, there are a lot of cells. Because there are a lot of cells, there are a lot of nuclei. And there are a lot of nuclei, there's a lot of DNA. So they'll take up more of toluidine blue and appear more blue in color. So that's how it works. So wherever there is a lot of cells and a lot of nuclei, there's a lot of DNA, so they appear blue. And that's probably indicative of a malignancy. So use a 1% aqueous solution, and usually followed by a 1% acetic acid to decolorize the cell in the protocol. And the abnormal tissue will retain the blue dye because it has more of DNA content. Just to show you how it can be tricky, the same case, which I showed you previously for VisiLight, the same ulcer, seen with toluidine blue. Now, when you compare these two, you look at it, there are some areas where both is positive in toluidine blue and it is positive with VisiLight. But there are a lot of areas in which VisiLight is positive, but toluidine blue is negative. So there is no one technique which is superior to the other. And you need to use your clinical judgment as to where to biopsy and where do you think your biopsy needs to be done. So to summarize, these are two different techniques which use the thickness of the epithelium and the amount of DNA into consideration. They are very good diagnostic aids when you supplement them from the clinical examination and the history. And they need not necessarily indicate the same areas for which you should take a biopsy. This is a very exciting field, and we feel that this is going to be the future of diagnosing lesions very, very early. What we do is we take a light source. It's usually a blue light source, like I said, for the VisiLight Pro, which is a blue LED. The wavelength is between 4 to 460 nanometer. It has an emission filter, and you see what is called a red-green fluorescence. And when the fluorescence is lost it indicates that it's a potentially malignant lesion or it is a malignant lesion. And then you take the biopsy from that particular site. It has got a fantastic sensitivity of 98% and a specificity of 100%. And you might have heard of things like Veloscope. The Veloscope uses fluorescence, and the Visilite Pro, the same company which launched Visilite, also uses the blue LED and depends on fluorescence to diagnose these lesions early. So what exactly is the principle for those of you who are academically inclined and want to work on this? It's very, very simple. When it is clinically cancer, you examine by visualization or by biopsy, you prove that it is cancer. Before it becomes clinical cancer, there are tissue alterations and there are cellular alterations. The tissue and cells change. And that is what we as pathologists do. We look at tissue and cellular alterations and tell them whether it's cancer or it's going to become cancer so that they can treat it quickly at this particular stage. But even before cellular alterations which a pathologist can look at occurs, there are biochemical alterations. There are alterations of enzymes. There are alterations of chemical components, which cannot be visualized under the routine microscopy. So you need to do biochemical studies to study these. It is this biochemical alteration which causes altered fluorescence. So by definition, the earliest change to happen before a cell becomes cancer is biochemical alteration. So looking at it the other way, before a normal cell initially has certain biochemical alterations, could be in its ATP, could be in NADPH, could be any of its enzymes. And once these biochemical alterations accumulate, it shows some changes in the cells, which you can look at in cytology. And once a lot of cells are affected, there's a change in the tissues, which is visible in the biopsy. And when this becomes a lot, clinically, you look at it as cancer. So technically speaking, fluorescence could be indicative of one of the earliest changes of malignant transformation. And these are from Google Images. These are not my slides. And this slide on the left, upper left, looks like a normal mucosa. But when you expose it to autofluorescence, you can see that this is the green fluorescence. And this red area where the arrow is pointing, this is the loss of fluorescence. There's no fluorescence in it. And this was biopsy then proved to be a moderate dysplasia, which is on its way to becoming cancer in a few of these patients. And once again, this is the tongue which looks absolutely normal clinically. I don't see any abnormality, and I'm sure none of you also see any abnormality. But when exposed to fluorescence, there is a loss of fluorescence right here. And this is probably an early indication that there are some cellular and tissue alterations or just a biochemical alteration which you need to follow up and make sure that it does not become a cellular or a tissue alteration and does not progress to become cancer. This is once again for those of you who are academically inclined. We have taken it a step forward. This is normal to potentially malignant to early cancer, stage 1, stage 2, and advanced cancer. There are histopathological changes, and I said there are biochemical changes. But even before biochemical changes can happen, there are molecular changes which can happen. And that is what we do in molecular pathology. All your P53s and HPVs, which you must have heard in the news, that's what we do. So even before your biochemical alterations can happen, there are genetic alterations. And that is what we catch using molecular pathology. So if you look at the diagnosis, one of the earliest changes at the genetic level or the epigenetic level that we diagnose using molecular pathology. Then you have biochemical changes which you can clinically diagnose using fluorescence as one of the techniques. And then you have cellular and tissue changes which your pathologist can help you to diagnose. And of course, with clinical cancer, your acute clinical acumen and experience can diagnose it at a very early stage before it becomes advanced cancer. So these are the steps we use to diagnose cancer from the early to the late stages. Quickly on how to biopsy. I don't want to take much of time on this because I'm sure a lot of people know this, but there's a few principles. So once again, it's taken from the same source. This is 1 and this is 2. We do not want a biopsy like what is mentioned in 2. It looks like you give us a lot of tissue because it is very broad, and the green, dark green is the tumor. But if you look at the base of the incision, it is very, very short of the normal tissue. So we don't mind having a normal, narrower wedge and going right to the deep. So if we need a choice between a broad and a shallow biopsy versus a narrow and a deep biopsy, always go for a narrow and a deep biopsy. In an ideal situation, if you can give us a broad and a deep biopsy, that's excellent. But it may not be practical clinically because there may be some limitations regarding bleeding and, controlling the patient's surrounding soft tissues appropriately. And this is another view of the same lesion. And when you take a biopsy, it should be elliptical. You want a lesion which is, the dotted lines indicate how your incision should be in the deeper part of the tissue and how it should be around the tissue. It should be elliptical and it should not be like this. You should not have a very sharp edge, and these are fundamental surgical principles. So two important points are the biopsy should be deep, involving the connective tissue. If you give us normal tissue, we are happy with that. But if it's a cancer and you give us only the lesional tissue, that's okay too. It should be narrow and deep. Lesions should be elliptical on both the dimensions, superior inferiorly and anterior posteriorly and medial distally. So all the incisions should be elliptical, which will enable appropriate closure of the wound. Do not have any sharp corners in your incision. That will invariably lead to wound dehiscence and problems with hemostasis. A quick word on punch biopsies. These are good tools, especially if you're not an oral surgeon and you're a little bit hesitant to put a scalpel. Punches come in different sizes. You get them, this is the armamentarium. So you put the punch, you rotate it quickly, and then use a tissue forceps to, elevate the punched specimen, and then you snip it off at its base. You need to do it very carefully, because if you do not do it very carefully, invariably a lot of punches we see, we get this sort of nice, it looks like a nice, beautiful tree, but it's inappropriate for diagnosis because this is where it was really crushed very hard. When you're holding this, it was crushed very hard using a tissue forceps or an artery forceps or an inappropriate tool. So you need to be very gentle when you do a punch biopsy. But punch biopsies are excellent, especially in field scenarios. If you're having a community work and you don't have access to scalpel blade and proper sterilization. So these punches come in pre-sterile pouches and they're not very expensive. You can quickly do a punch. And if you use a small punch, very many a times, you need not even do a suture. So in field scenarios, it's very good. Or even in your clinical context, the patient is very apprehensive of a knife. You can quickly do it within a few minutes. And if you do it very carefully and choose the appropriate site, you need not even suture the lesion very many a times. So this is a good tool to have in your armamentarium when you need to take a quick biopsy. This is one of our cases just to show you how the lesion should be elliptical. This is the ventral surface of the tongue. You look at the elliptical nature. Though it looks like, this is an excisional biopsy of this leukoplakia of one of our patients. Though it looks like a huge excision, because the margins have been properly undermined and the incision is elliptical in both the planes, deeper and on the surface, the moment you suture, you get fantastic closure and good hemostasis, good control. So the trick here is to go deep till you reach the connective tissue, not be very shallow, and make sure that your incision is elliptical along all planes so that when you close them, you get appropriate contact, appropriate closure, and good healing and good control of hemostasis, even in a very vascular area like your ventral surface of the tongue. In fact, you can see a vein right here. So if you do it appropriately, you can get very good biopsy, which is both diagnostic and least amount of morbidity as far as the patient tissues are concerned. Okay, to summarize all this quickly, what I have tried to convey here, and hopefully I've done that effectively, is you need to have a good history, a good clinical examination and investigation, because there are a lot of lesions that can look like cancer but are not cancer, and vice versa. Most of the cancers in the oral cavity associated with habit have a potentially malignant stage, so if you can catch them at this stage, it is good. And even if it is cancer, if you diagnose it at an early stage, it is good. Why is it good? Because stage 1 to stage 4 is a difference of total cure to very bad prognosis. 100% cure to less than 10% or 20% cure with stage 3 or stage 4. Of all the tests you have, nothing replaces a good visual examination along with a history and clinical examination. But very many a times you have to depend on adjuncts, and there are different types of adjuncts such as chemiluminescence, toluidine blue, and fluorescence. And I briefly told you what the principle of these were so that you understand how effective these are. They all have the limitations. Fluorescence looks at biochemical changes. And if you want to go even earlier, you can look at molecular changes. And this is my final slide. This is the algorithm which you can follow. If you have a patient, see if the patient has a habit or not. No lesion, have habit cessation counseling. If there is a lesion, cessation counseling and investigation. For the investigation, you can use your diagnostic aids or adjuncts. I told you what the limitations of cytology are. White biopsy is the gold standard, and other methods you can use along with it, such as chemiluminescence, toluidine blue, and fluorescence. You manage, you follow up, and once again, cessation counseling. This is very, very important. You diagnose and treat the patient, but counseling the patient periodically for cessation of tobacco is important. And numerous studies have shown that dentists are very, very good medical personnel to actually do a very effective tobacco counseling cessation. So in addition to appropriate diagnosis and management, you have the added responsibility of counseling these patients to stop their habit. It could be tobacco, it could be areca nut, or it could be a combination of these with alcohol. So let me stop here, and thank you all for giving me this opportunity and sharing some time with you all in this forum. Thank you very, very much.
Thank you so much, sir, for sharing your immense knowledge with us. We are happy to announce that we have more than 500 viewers and participants for this webinar. We are coming towards the end of the session. I now request Dr. Sudhindra Prabhu, Professor, Department of Oral Pathology, to deliver the vote of thanks.
Good afternoon, one and all. Ranganathan sir, thanks a lot for that wonderful presentation. Really, it was informative, and we had a wonderful response, more than 500 delegates today. And we thank you, sir, for accepting our invitation and delivering this lecture to us, sir. And we would like to express our gratitude to the management of Yenepoya deemed to be university, Honorable Chancellor, Honorable Rose Chancellor, Honorable Vice Chancellor, and respected Registrar, sir, and our dynamic Dean, Professor Dr. Akhtar Hussain, sir, for all his support and encouragement for all our endeavors. All the Vice Principals of Yenepoya Dental College, our HOD, Dr. Riaz Abdullah, the team, Oral Pathology, YDC, all the faculty members and postgraduates of Department of Oral Pathology, Yenepoya Dental College, the faculty and postgraduates of all the departments of Yenepoya Dental College, and of course our IT department, which allowed us to live stream this program on the YouTube also. And of course, the last not the least, the delegates. It's a huge response. So we thank all the delegates who actively participated in this program. Thank you, one and all. Have a nice day. Thank you.
Thank you. Can I log out?
So there is a question for you, sir, from the audience.
Yeah, please.
Can you please explain about the diagnostic aids in diagnosing post-treatment recurrences in early stages?
Okay, let me see if I got the question correct. Diagnostic aids in post-treatment, what was that?
Recurrences in early stages.
Early stages, okay, fine, good. Which I presume what you're trying to ask is the patient has been treated, and then when you're following up, there is a new lesion. Is that correct? Was that the question?
Yes, sir.
Yeah. Now we enter into the realm which I didn't discuss. So when you get a new lesion, there are certain possibilities. One possibility is it could be a recurrence, a local recurrence. Another possibility is it could be a second primary, and the third possibility is it could be what is called a second field tumor. And these things all have different molecular profiles. They have different approaches to management. But all the diagnostic aids which I told you now, for clinical examination, using of toluidine blue or fluorescence will be useful. Most of the times, at least in our practice, what we do is we have the thorough photographs of the patient, the primary photographs, and we have the primary biopsy report and what treatment was done. So very many at times we don't fall back on clinical agents. We don't do biopsies, we don't do we don't do exfoliative cytologies or brush biopsies. We straight away do an incisional biopsy, depending upon how far this lesion is from the original or the primary lesion which was treated. It could either be incision or excision, and straight away go on to do a biopsy. So in the recurrence, there is no element of doubt that it's breast cancer or not. It probably is. And the question is whether it's really only severe dysplasia or early cancer, or is it a second field tumor or something new which has come up in place. So that's totally a different ballpark from a primary lesion. Hopefully that answers your question.
Sir, is there any molecular analysis regarding this, sir?
Yes, there are a lot of molecular analysis, and I specifically avoided that, keeping in mind that this is the IDA is also part of this, and there are clinical practitioners. There are tons of markers. We could have an entire session on that. There is no one specific marker. So the rule of thumb is there is no one marker which says that this is malignant or not malignant or it's going to come back. There are markers of growth like EGFR. There are markers of mutation like P53 or what are called tumor suppressor genes and RB genes. There are markers of senescence and longevity like telomerase. There are markers of apoptosis like BCL2. So this is very complex. There are a lot of markers, and each one of them has got significance in different connotations. But in oropharyngeal cancer, which I didn't touch upon, human papilloma virus, HPV, there is a marker called P16. If it is an oropharyngeal cancer, I'm not talking about oral cancer, more of oropharyngeal cancer towards the oropharynx, you could do a P16 marker. And if P16 is positive, that could indicate the presence of a high-risk HPV, 16 or 18, which is there in most of the oropharyngeal cancer. It's a marker in that context.
Sir, another question, sir. How effective is Raman spectroscopy in the diagnosis of precancerous lesions?
Very effective. In fact, I think one of my graduate students has just completed a project on that, and it's still lying on my table. It has a role, because that's why I always like to say what is the basis behind any of the tests we are doing. And if you remember the flow chart which I showed you, biochemical alterations are one of the earliest things which happen in the tissue after genetic changes. So all these things, fluorescence spectroscopy, Raman spectroscopy, there are something called, optical microscopy. There are so many different techniques are there. They try to look at the biochemical alteration. So any test which looks at biochemical alteration is going to be effective. Of course, it needs to be validated in the clinical context. So if anybody's interested in research, those are areas which you could address as research is concerned.
Sir, as the YouTube is streaming late, and due to the sparsity of the time, we will take the questions later and mail you, sir.
Appreciate that. Thank you all. Thank you all for a very nice program and giving me the opportunity.
Sir, I have a question. Can I?
I can't see your face, so I don't know who's asking the question. So it's okay.
Sir, I'm Dr. Hari Kishore from Yenepoya Dental College. I have a question regarding histological markers for distant metastasis in squamous cell carcinoma. We have few cases where there is no loco-regional failure, but still there is distant metastasis. So as oral pathologist and with vast experience in this, I would like to know whether there is any particular histological feature which you can point out to identify such lesions which can go for distant metastasis.
You're asking about a histological feature which would be suggestive of distant metastasis. Okay, good. Yeah, we know.
Is there any?
Yeah, that's a good question. It's a very difficult question. If you look at the latest AJCC classification, the CAP, the American Journal for Cancer classification, you will see that they have introduced a new parameter, what is called, depth of invasion. I mean, if you're aware of it.
Yes.
There are two things here. There's what is called tumor thickness and depth of invasion. Depth of invasion could actually be a very, very good indicator of prognosis, and that it is going on to a later stage, which implies that the risk of metastasis is always there. As the stage progresses, the risk of metastasis, nodal metastasis is higher. So that is one thing. So that has now become mandatory in staging all these tumors, because the depth of invasion could be an indicator of a higher stage, which indirectly could be an indicator of the risk of metastasis. Of course, in routine biopsies, if you see that you have embolus within a blood vessel, a tumor embolus within a blood, that could be an indicator. But even that does not ensure metastasis, because metastasis is a very, very complex process. The tumor cells have evaded so many immune system problems. But yeah, one of the things is the depth of the tumor margin. So that could be a useful indicator actually.
Yes. Thank you, sir. Thank you.
Thank you, sir.
Thank you.
Sir, we'll wind up, and thank you all the participants for joining in this webinar.